very.
Potentially, yeah. Not a lot of what we actually, as EMS, not a lot of what we deal with. So certainly a high risk there. So we kind of need to have a clue about it. But it's not like respiratory or chest pain type stuff, right? Okay. All right. So our goals, right? So if somebody takes a poison or they overdose on something, what's our goal? What do we want to do?
Stop it, or
Right. So the ultimate goal is to prevent. So in pharmacological terms, what are we trying to prevent? The absorption part, right? So I want to prevent the absorption. So what are some ways that I can do that? So get it out. Okay, so I can bind it up, okay, and so it's inactive, certainly. Or get it out, and there's a couple ways I can get it out. How can I get it out?
I'm saying make you vomit it up.
Okay, so we can vomit. So certainly we can vomit it up. What else? How else can we get that out?
Poop it out.
Oh, make it go out the other end. Okay. Yep. And or lavage kind of stuff. Right. Yep. Okay. So yeah. So the goal, right? So prevent the absorption, enhance the elimination, or we have specific antidotes so that we kind of know what they are. All right. All right. Right. So prevent the absorption. You guys kind of mentioned that, right? So gastric lavage. How beneficial is that? Does it actually get everything out? No. Yeah. So in fact, kind of what's the problem? So if you take something, so you guys ate today at some point, right? So where's that food sitting at now? So what does your stomach do to it?
Breaks it down into like sludge type thing?
It actually kind of, as it goes in your stomach, basically because it's that churning action, actually creates a little ball of food. So originally, if you recently ate, basically you have a little ball of food. It's called a bezoar. Bezoar? I think it's a bezoar, something like that. So you have a ball of food there. So when you put fluid in there to lavage, what are you doing? What's coming out?
The ball of food?
Nope. The stuff that's floating, because there's something certainly it's floating, because as the acid's in there, it's breaking down the outside stuff on the outside, and certainly that the mechanical action is kind of compacting things and compressing things. But generally, when you lavage, and why lavage isn't such a great thing, is that you're not getting everything out because whatever this ball, if the ball exists, it's not coming back out. Make sense?
So what, 30%, something like that gets out?
I want to say it keeps 30. I'm going to say it gets everything but 30%. I think. Okay. So another way to bind stuff up is basically for activated charcoal. What's charcoal do? Yeah. So basically, it's literally it's kind of like charcoal, right? So it basically kind of binds to the products and basically makes it to where the body can't absorb it. And so now it just has to go through the system. Okay. And serpigicac is another one. We'll kind of talk about that. Serpigicac has really kind of lost favor. So you will probably never ever use it. Well, I shouldn't say never ever. In the next several years, you're not going to use it until it becomes kind of in favor again. Serpigicac has the same kind of problem as lavage. The idea is that we want to vomit everything up. We used to kind of think, oh, we vomited everything up. Well, no, there's actually still a lot of that in there. What's not coming up is basically that ball. And serpigicac has a couple other things. We'll talk about that, right? So activated charcoal, heard of this Actidose charcoalate, okay? Very high surface area, absorbs things. What doesn't get absorbed very well? What does charcoal not work with?
Like pills?
Alcohol?
Yeah, it has a very, very poor affinity for alcohol. So strong acids, strong bases. Mm-hmm. Yeah. So it doesn't really kind of work with everything, so we kind of have to watch. So if it's, and I think we kind of get in, yeah. So acids, alkalines, caustics. So really doesn't work at all. Has a very poor affinity for your alcohols, the methanol, ethanol. It has a very poor affinity for it. It will bind some, but very little. Cyanide's the same thing. Your caustics, iron doesn't bind at all to it.
What would give you an overdose of iron? I mean, just, I mean, besides the pills.
Well, but like a processing plant, so basically if you get basically where it's just dumped on you, so like a big industrial site, that's generally where you get a lot of the heavy metal stuff is like at a production facility where they use it as part of the process of whatever they're making.
Okay. And it's like is it like just dusty or something, and it gets inhaled?
Yeah, it can, or it get put on food or yeah.
Oh, gotcha, okay.
So you're medicated. So serpico, right? So this stimulates the chemoreceptor trigger zone, right? And has a direct effect on the gastric. That gastric then stimulation runs basically and goes straight to the vomiting center, right? For the most part, it worked 90% of the time within 30 minutes. So what's the problem with that, though, if they took 100 Valium pills?
Most of them are gonna be.
Well, you have to have a gag reflex for it to work, right?
We gotta be conscious.
Right. So if it takes 30 minutes to work,
Oh, I mean, half of it are, I mean, a lot of it already ingested.
right. So in the meantime, we've got 30 minutes. So where they are now,
You can't.
it's right. So now you're able to protect your airway. I'm happy. Here, have this. 25 minutes from now, and now I'm going, please don't vomit, because you cannot protect your airway.
Usually they're not calling until they're already at that point anyways, or somebody's not calling.
Yeah.
I mean, how often is somebody going to down
Well-
that much and be like, oh, hey, I just did this?
Actually, yeah, they do. There's a fair mix, because they generally don't. Because basically, if you walk in and I'm mad at you and I took all my pills and I'm going to go call 911, or you're going to go call 911. It's kind of rare that we get there, because generally when we I also get the other ones where I'm mad at you and I come home a couple hours later and yes, that's how I find you. But yeah, you get a fair mix of all of that. All right. So, and because of that, basically it's rarely used, right? Generally, if you can give it to them. If within 20 minutes they haven't vomited, you can certainly repeat it. The problem is it only leaves removes about 32% of the toxin. So it leaves most of it in there, and we kind of really have to predict where are they going to be. Folks that took mixed overdoses were really kind of going, I'm not really sure how all that's going to combine and affect, and where are you going to be at in 30 minutes. So for the most part, this is really lost favor. The American Academy of Pediatricians was kind of the last stallard. The poison centers for years have been saying we want to get rid of it, we don't want it anymore, because they used to kind of say this is something you should keep at your house. So probably about 5-10 years ago, they really kind of stopped saying that. So you can still certainly buy it, but it's not something that if you call them, they go, we're not going to talk to you about it. So now if you have it, and you say I have it, they might ponder that idea, but for the most part, because of all these issues, they say no. Okay. Yeah. So contraindications kind of make sense, right? So the comatose, they've seized, or they're going to seize, or they might seize. They have a seizure history, they're hypoxic, whatever. So again, obviously, if they seize, they're not able to protect their airway. So again, caustics and acids, alkalines, why don't we want those?
Cause damage on the vomit.
Right. So they cause damage going down. When they come back up, they're going to cause more damage. Okay. Low viscosity hydrocarbons, kind of basically the same thing. Actually, the risk there is aspiration. Okay. And then kind of late-term pregnancy. So yeah, you have this. I mean, if the diaphragm's not able to move, you're not able to contract those muscles. It's not as effective. Okay. And then certainly contraindications, you have these phenothiazines, tricyclics. Basically, all of these can certainly lead to seizures. If the overdose that they took on can lead to seizures, you don't want to give it. Okay. So things that enhance eliminations, right? So we talked about the cathartics. The other ones, and you guys have talked about this before, urinary pH manipulation. Okay. So the cathartics, so the mag, citrate hydroxide, right? So basically draw water into it, increase the stimulation, move things up. Okay. The things we have to kind of watch for is just basically dehydration and then electrolyte imbalances. So the cathartic, so we talked about this other one, here's sorbitol. This is one, so within the activated charcoal, a lot of them actually, if you'll look, it says activated charcoal with sorbitol. This is why. It's a cathartic. So not only do you want it to kind of bind everything, you also kind of want it to let's move it out so it gets out of the system. Alrighty. Yeah, other stuff. Yeah, and this is kind of my favorite, right? So I think you talked about it earlier, right? So here's one, go lightly. That's my favorite name. Yeah.
So you give it to a lady once with it, it was nasty smell too.
Yeah. So, right, so basically these are osmotic. These basically cause increase in osmotic effects, and basically move things along. All right, so urinary pH, right? So you guys talked about this, right? So you give sodium bicarbonate. When you give sodium bicarbonate, what are you doing? Okay, yeah, so you're changing the pH, which then causes what? Right, so basically, so if it's, right, because basically things, acids get absorbed best in what type of environment? Acidic environments, right? Because basically what you're doing is you're basically kind of changing that. Remember, there's a balance between the hydrogen and the acids, because the hydrogen and the acid are basically the hydrogen and whatever the product is, which is basically, I guess, the acid. In their, the things that get through a membrane are what? What are the characteristics of things that easily pass through membranes? Small, uncharged, right? So the hydrogen ion is a charged ion, and then acid's a charged ion, so they don't get absorbed easily. So when you basically change the pH, and it's no longer as acidic, that acid, now more of it, instead of it being absorbed, actually gets excreted out. Make sense? Okay. Right? So yeah, so it increases, raises the pH, ionizes the acids. As they become ionized, they can't cross the membrane, okay? And now we get rid of stuff. So right, so basically salicylates, phenobarbital, basically things that are acidic, we can do it. Acidification, basically kind of the same concept, just kind of opposite. So we have cause a base to become ionized. Again, prevents reabsorption. We move things along. So amphetamines, phenylcyclidines. Okay. Now, rarely do we do this. You know what myoglobin is? So there's hemoglobin. What's hemoglobin?
When the red blood cells carry oxygen.
Right. Myoglobin, similar concept, but instead of being in the blood, it's in the muscles. So it's a storage site, so basically for O2. Okay? But that myoglobin, basically when the muscle cells get destroyed, that myoglobin now basically goes, and when it gets into the kidney tubules, it clogs them up, basically. And so they don't become as effective. All right, so in specific antidotes, naloxone, what is this?
Narcan.
Okay, and it's used for, okay. How's it given?
IV.
Okay. But
Or into.
how? Well, certainly can, but how? What's our goal?
Until
To block
the effects are seen.
Right, basically, right. So it's not as, I'm just going to give it. You give it until you start to see, aha, I have a return of respirations, right? So, or an improvement of respiration, so certainly, okay? Flumazine, what's this?
Stop seizure. It's an overdose. Anti, whatever for benzos.
Yeah, so Ramazicon the other name for it. Yep. So basically similar. It's an antagonist for benzos. All right. So works with the GABA sites. Basically stops that functioning of it. Okay. Now, normally when we use it is to reverse iatrogenic benzo. So what in the world does that mean? What does this mean?
It's only used for benzos. Or benzos.
It is, right? So yeah, so this doesn't, so you have a mixed overdose, not something necessarily you want to do. What's iatrogenic mean? Hospital caused, hospital induced. So we gave too much of it. So like in the OR, we're trying to basically sedate somebody, and we pushed a little bit too much. I know I pushed it. I know I gave too much. Now I can reverse it. What's the risk of giving this?
You can reverse it too much.
Well, yeah, but
You can't stop.
so they develop seizures for whatever reason. They develop seizures. Your therapy for seizures no longer works. So very good. All right. Actually, did we do that? Yeah, the big thing should never. So this, and even in Narcan, we can kind of, maybe we can try it, maybe we can't try it. So certainly if you're kind of going, I'm not so sure, we can certainly try it. With this one, don't. Because when you get into the mixed overdoses, the concern becomes seizures. But the concern should be seizures. Okay. Atropine, right? So it inhibits acetylcholine. Right? So basically you get organophosphates or carbonates. Those basically lead to cholinergic effects. Right? So it's sludge.
Television,
Right? Excellent. So, right, so basically atropine causes the anti-sludge effects. Okay. Alrighty. So 2-PAM. Proladoxamine. How's this different than atropine?
Atropine, you have to get it in huge
That one
dose.
just blocks.
Yeah, this one like it says reactive because when you have
Reactive with enzyme that
poisoning,
breaks
it
down.
Right.
blocks the
Yeah, right.
cholinesterase, which
Because
inhibits
the problems with organophosphates and carbonates is that they are binding acetylcholinesterase. Okay. So when you bind this, and what does acetylcholinesterase do?
it
Breaks down
inhibits
acetylcholine.
Right.
comparison.
So there's nothing to break down acetylcholine, so there's lots of acetylcholine. So there's two options there. You can either block the acetylcholine receptor site, or you can cause this to separate. The 2-PAM causes this to separate. So that acetylcholinesterase now becomes effective, and now it starts to break down the acetylcholine.
But does that atropine is not a complete cure though, right?
No, yeah, because until your body either produces more acetylcholinesterase, or you...
Well, how long will that take?
yeah.
Depending on
So you can give atropine just a short term, stop
Yeah.
it, and then this to
Correct.
start reversing the process.
Correct. Atropine's kind of the initial, let's kind of fix this. This is kind of more the long-term fix. So, or they just put them on an atropine drip.
So if you have your phosphate and it's in there, so then 2-PAM breaks it apart, or it uncoupled it from the
Correct.
cholinesterase. Okay, so is the organophosphate still in your body? Can it bind with another cholinesterase receptor? Or when it unbinds, does it like kill it
Yeah, it's inactive or something.
or inactivate it? I mean, do you just have them like binding and unbinding and binding and
I think it's,
unbinding?
yeah, I
all
think
over the-
all of these are kind of, because you look at all medications, they all have half-lives because they all have metabolic rates. So the organophosphate has a half-life as well. So that's in the system until the system kind of breaks it down. So what you have to kind of do is kind of know the half-life of what you're dealing with and the half-life of your treatment. So in a lot of cases, kind of like, like I told y'all the story of basically the Narcan and the opioid overdose that I had. Right? So certainly we fixed it, but yeah, we really we needed to watch them when they got to the ED. Basically, they got an infusion. They basically had a bunch of Narcan stuck in an IV bag and basically just gave an infusion of Narcan. Because the opioids had a much longer half-life than the Narcan did. So you have to balance that out. So I don't know exactly how it works, but certainly there's other stuff kind of floating around in there that kind of plays a role. All right, so calcium, which go figure. You have the calcium channel blocker, you can give calcium. Right? And that kind of makes sense. So there's more calcium in your bloodstream. Now that when you have the calcium channel blocker, it's less effective. All right, sodium bicarbonate. So there's two components to sodium bicarbonate, remember, right? So there's the sodium and the bicarb. The bicarb causes a pH change. The sodium you can actually give for sodium. So basically you have a sodium channel blocker overdose. So basically for the type 1 antidysrhythmics, the TCAs, you can actually give bicarbonate. You're not giving it so much for the pH effect, but basically because I want to give a big bolus of sodium. Or you can just give hypertonic saline. All right, glucagon. And what do we say glucagon? How does glucagon affect the beta blockers?
Indirectly. Do the same messenger.
There you go. All right, N-acetylcysteine, also known as mucomist. Y'all remember what this is for?
Mucolytic.
It is a mucolytic, but it's also used for overdoses.
Overdose?
Also used for Tylenol overdoses. Yep. Okay. Because remember we talked about how Tylenol has two pathways. It has a primary pathway, which doesn't result in toxicity, and has a secondary pathway, which uses that P450 enzyme that ultimately results in, is it formaldehyde? Aldehyde? Anyway, it results in a toxic byproduct. And so if you have too much of if the primary road is full, it diverts stuff to the secondary role. So, but that secondary pathway has another chemical in there that basically helps break it down into a non-toxic event. The problem with the secondary pathway is that there's only so much of that secondary. So that the N-acetylcysteine basically helps make sure there's enough of that other product. So when it does go through that secondary pathway, it ends up in a non-toxic state. That makes sense?
So it doesn't block the secondary pathway, it just...
It's not really that it blocks it, it allows it to go to completion. So there's kind of like 3 steps, and if you're missing that last enzyme, only 2 steps are done. So the mucomist kind of ensures that all steps are completed. All right. Ethanol. What's ethanol? Alcohol. Ah. What's methanol?
Antifreeze.
Yeah. It's kind of wood alcohol, right? It's a different type of alcohol. The problem is, and we'll kind of get into it, methanol basically can end up in some toxic effects. But, so you drink too much antifreeze, the treatment is actually to give ethanol.
So if your dog gets into it, you can give your dog
Schnock removal?
like Jack Daniels or something?
Yep.
That's awesome.
Yep. All right, so here's how it kind of works, right? So methanol basically uses alcohol dehydrogenase as an enzyme and forms formaldehyde. You ever heard of formaldehyde?
Mm-hmm.
What's formaldehyde used for? It's a embalming fluid. Sounds pretty bad, doesn't it? Yeah, right? So we have formaldehyde, but as long as we have aldehyde dehydrogenase, the formaldehyde becomes formic acid. Okay? Ethanol, right? So alcohol dehydrogenase, you heard of that before, right? But ethanol becomes acetylhydronate. There's the aldehyde dehydrogenase becomes acetic acid, basically becomes CO2, water, and energy. Right? Methanol and ethanol both use this alcohol dehydrogenase. Right? Remember, the problem with methanol is it ends in formaldehyde. Okay? So when you give, basically, if somebody has ethanol and methanol, the alcohol dehydrogenase prefers methanol. It's like its best friend. It's going to go hang out with it.
Ethanol.
Ethanol. Ethanol is alcohol dehydrogenase's good friend. They're better friends than methanol is. So when all 3 are present, alcohol dehydrogenase likes ethanol better. Okay. So that basically goes through its process, leads to acetic acid, leads to CO2 and energy. Methanol, in the meantime, is hanging out by itself, and he doesn't feel very warm and welcome, which is good because we want to get rid of methanol because methanol can end up in formaldehyde. Methanol basically gets excreted by the urine in a non-toxic state.
So can we just take them to the gas station and buy them a 12-pack, take them home?
Yeah, you put that liability on.
Yeah. All right. So, but that actually is one of the therapies. Is that what they used to do? Is they actually would give folks, once they kind of figured this out, they'd give them an infusion. Actually, it was just an IV. They basically just gave it through the IV. Yeah,
It still have the same effects, though.
it would.
Just be happening quicker.
But
Yeah, but you wouldn't be.
not to disappoint you,
conscious.
somebody figured out this. Fomazepam. Yep. It inhibits the alcohol dehydrogenase. However, it doesn't cause the intoxication. Yep. All right. Digitalis. What's digitalis? Heard of it?
It's a cardiac drug.
It is.
Toxin.
For what? Anybody know?
Digoxin.
No, it's a cardiac glycoside.
Oh, yeah, sorry.
Excellent.
From the foxglove plant.
What in the world does that mean?
I don't know. For AFib or something, isn't it?
It's for congestive heart failure. Right? So folks that basically kind of, digitalis basically causes an increase in the oomph of contraction. And so folks that basically who have had an MI, who don't have as much heart muscle, what's left, they basically kind of need some extra help.
So just extra pump, just to help. keep
An
the
extra
fluid
oomph.
to
Right,
go.
so it has some more oomph behind it. It basically causes an increase of intracellular calcium. Okay, so it messes with the sodium potassium pump, which then causes a change of cellular calcium.
Calcium is positive.
Positively charged.
Strengthens the force of the heartbeat, increases the amount of calcium in the cells.
Yeah, well, the calcium causes that increase in oomph, so it's not kind of the other way. But yeah. Now, what's the problem with Dig?
It has
The overdose
very
on it.
high, or very low therapeutic index.
Excellent, yeah. Right. So it basically has a therapeutic index of like 1,
Right, so
which is like,
you mess up.
yeah. So very easy to become toxic on it. You become toxic on it, you basically start seeing halos, bad things start happening. Okay. Digibind basically binds. It binds the digitalis, and then basically gets excreted. All right, chelating. So chelates, basically think of chelates are big claws. Chelating agents are for heavy metals, lithium, iron. Okay. So basically, kind of it means it combines to and promotes excretion of heavy metals. Okay. So the thing is, you have to have the chelating agents, and you have to know what they've done, and basically know the chemistry. So just kind of understand. So you get someone that's been exposed to heavy metal poisonings, call the poison center because they got to start figuring this stuff out. Okay. But yeah, so so arsenic. Those are the ones that basically get used. All right, how we doing? Need a break? Keep going. All right, we're just going to keep going. Oops. All right, so eyes, ears. All right, so things we're going to talk about. Glaucoma, mydriasis induction, ophthalmic anesthetics. Doesn't that sound exciting? What's mydriasis?
Dry eye.
Oh, water eyes.
Nope.
Crisis.
What happens when you go see your eye doctor? What does he do to you?
He gives you.
Aha.
That sucks.
Mydriasis is dilation. What's constriction?
My I
Myosis?
don't know. Try to make up a word.
Okay. All right. So what's glaucoma?
Degenerative disease of the optic nerve.
Outstanding. Tell me more. How's it work?
It's gonna put a lot of work. Okay, yeah. I'm sorry.
Go ahead, Ethan.
No.
I don't know, it's associated with an increased intraocular pressure.
Where?
In the back
You're
of the eye.
absolutely right.
Intraocular.
Actually, it's not in the back of the eye. It's in the front of the eye. And it's therefore called what chamber?
Anterior.
The anterior chamber. And it's which fluid?
Aqueous humor.
Outstanding. So you have too much aqueous humor. And there's a couple ways you can get this. Overproduction or we're blocking the pathways to get it out. Okay? And there's actually kind of more, because you can actually have low pressure glaucoma as well. But most of it, 80% of glaucoma is kind of is the increased in intraocular pressure. So there's other stuff that can kind of lead to this, but yeah, ultimately glaucoma leads to a damaged optic nerve, right? Okay. Most of the stuff that we kind of focus on basically kind of focuses on either minimizing the production of the aqueous humor or ensuring that we're kind of getting it out. Okay. And there's open angle glaucoma and closed angle glaucoma, and there's a couple other things I'm not going to kind of get into. When we get into the eyes and ear stuff, we can get into that. Okay. But here, so beta blockers, this limits production. So they actually have beta blockers, and they actually have drops that they put in the eyes. And what it does is it limits the production of the aqueous humor. Not as much production, less pressure, not limiting the damage. Make sense?
So all it is just, like you said, an overproduction of it, which causes...
This is very much of a simplification of it. There's certainly a lot more to it.
And they get real cloudy, eyes get
That's
cloudy.
cataracts.
Oh, okay. All right.
Yeah. Glaucoma is just typically too much pressure. Now, like I said, there's low pressure glaucoma as well, but most of it's high pressure.
So these are the beta blockers, those are just drops you put in your eye
Correct.
specifically for your eye?
Correct.
Okay.
Yeah, so it's a beta blocker that you just drop in there.
It's not going to do anything systemically, is it?
No. Well, it's kind of like taking a beta agonist.
Yeah.
You typically don't get the systemic effects. Right? The cholinergics basically cause, there's that word meiosis, right? Pupillary constriction, as it kind of constricts things down, what it's doing is kind of starting to squeeze the anterior chamber, and it kind of pushes it out. Okay. All right. Diagnostic mydriasis. This is basically what they put in your eye. And basically, when you go to the eye doctor and they dilate your eye because they want to look in your optic nerve and look at your retina and check out all that. What are they looking for, by the way? Glaucoma's pressure test.
The deal with diabetes, like
Diabetic
the vessels, yeah.
Okay, I'll take that. What else is back there? So you guys study that in patient assessment.
The vessels.
Okay. What happens to the blood vessels? Because the eye is the only place where you can actually look inside and see the blood vessels.
Look for any ruptured blood vessels? Or?
Yeah, right. So basically, with hypertension, you're basically looking for remember the cotton wool is the exudate. Okay. With diabetes, it's kind of the same thing. So basically, you're looking for damaged blood vessels. So when you go in there and look for the cotton wools and the exudates and all that stuff, that's actually kind of what you're doing.
What is that? Cotton wool?
Is this all new?
Yeah.
We never heard of that.
Really? So Jason didn't do, y'all, or whoever, Jason or Jason, actually I guess it was Jason.
It was Jason, I'm pretty sure.
Yeah, I bet it was Jason. I'm going to have to Spock to Jason. Spock to Jason? Yeah. So the little presentation, the eye and ear presentation? Okay.
Like, which section was it? Bathroom?
Patient assessment.
That was so long ago.
No.
I don't really...
I don't
I
remember that at all.
Okay.
remember about the eye and ear.
Hey, speak of the devil.
That term.
And he appears.
So did you do patient assessment or they do patient assessment?
What?
Who did Clark? Which Jason
I
did
did.
patient assessment? Okay. Did you go that PowerPoint with the eyes and ears, where it talks about how to do the assessment of the eye? Evidently not.
We're all on this as 3 questions.
Well, all right. All right. Well, then we'll find it and put it up. Actually, I bet you it should probably be in there.
Show 9, intact, here's near, nothing bleeding.
So, but yeah. So basically, when they dilate them, what they're doing is looking for the going back and looking at the optic nerve, basically looking at the shape of the optic nerve, and then basically they're tracing through and looking at all the blood vessels to kind of see if there's any damage. Make sense? Okay. What else we do? Okay, local anesthetics. So basically, if somebody gets wood, metal, they basically get an impaled object, causes lots of pain. Basically, some EMS systems basically carry anesthetics. They're similar to lidocaine, not quite there, but basically where you kind of put the drops in the eyes and basically they numb them up. In fact, if you go to your eye doctor, a lot of times they actually do that because when they check for your pressure, so when they put there's a little pin that they poke on your eye, they basically put little anesthetics in there so that when they poke on your eye, it doesn't cause you pain. Because they actually push on it to see how much pressure is in there. So when they do glaucoma.
But the
I
drops
thought there's a
hurt,
thing
they
with
hurt
air, but
really
they
bad.
do-
Some do the air.
Okay.
use
It's
that
not
blue
as
light,
effective.
blue light.
Okay.
Yeah,
I didn't know they're
that's
actually
it.
touching
Yeah,
your eye.
yeah, they actually come up and they touch your
Yeah,
eye.
I know it got
Mhm.
caught in the flinch.
Yep. Yep. And the adrenergic agonists basically kind of work along with, because those are for, yeah, but it opens up because basically there's the iris and then there's the ciliary muscles, which allow kind of for focusing. These basically paralyze the ciliary muscles. So. Okay, so ears. What happens to ears?
Get infected.
Okay, so we can have internal or external.
Or middle.
Right. So right. Well, basically, kind of the middle and the internal ear are basically kind of behind that membrane, right? And so with the otoscope, or actually, yeah, the otoscope, right? So you get in there and kind of look at the membrane. All right. So yeah. So basically, you can have an external ear canal infection, right? So in which case we can basically kind of put drops in there, or you can get basically what a lot of folks get is kind of the swimmer's ear, where basically they get water in there. So there's different ways to kind of draw the water out and kind of minimize that. So basically, alcohol. There's a couple of different. My medical director in Huntsville was a big scuba diver, and so he had this. I forget. I have to go look it up, but atropine, alcohol, and something else. Anyway, it was like the greatest swimmer's ear cure there was.
So you just put those drops in your ears?
Yeah. Also can have ototoxic side effects. So what in the world does that mean? If it's ototoxic. Yeah, it leads to tendonitis. Basically, it's kind of a ringing in the ear. But basically, if you overdose on certain medications, then actually they're toxic to your hearing process. Okay? Aspirins, NSAIDs, erythromycin. Basically, if you take too much of those, what you start to get is kind of tendonitis, which is ringing in the ears, which is basically an indication that you've taken too much. Yeah. Earwax is another thing that you can get in there, right? So if you have too much earwax, but some folks actually have a lot of it, and if there's enough of it, you basically get hearing loss.
Permanent hearing loss?
No, just until this is removed. All right. Skin and diet. Wow, so here's a whole slide. We're going to talk about skin and diet in the skin and diet slide. All right. So talk to me. What's the skin? So think of medicine-wise. So let's do this. So what's the purpose of the skin?
Protection.
So certainly protection, right? Keep the bad stuff out, good stuff in. Fluid regulation, thermoregulation, right? So did we put stuff on there for that? Why do we put stuff on skin?
Protect.
So certainly to kind of protect it from it being damaged, okay? In a lot of cases, kind of for beautification in some purposes. Okay? So one of the big things we kind of look at is the irritation. So if you get an itch, what's the itch called?
What's it called?
Yeah. So what's the medical name for I have an itch? Pruritus. Pruritus. Okay. So we get anti-itch medication. okay, which basically you can kind of put on there, right? So you get the like a bug bite or bug sting. You can kind of put stuff on there, right? Okay. Cleansers, right? So what? So who? Yeah. So to clean the pores, kind of so folks that have acne or pimples or all that stuff, right? You can kind of clean the pores out and kind of make sure that nothing's stuck in the pores, or you don't get an infection inside the pores. Emollients, liniments, protectants are all kind of similar. Basically, an emollient basically ensures that the skin stays moist, and there's a couple ways that those can work. Basically, you can kind of put a layer of stuff over it so that you don't evaporate moisture. If the skin has an increase of level of moisture, that also kind of decreases the itch effect as well, but it also increases the protection. Some of those emollients will actually cause an increase of production of fluid in the skin. Protectants, again, you can get like sunscreen protectants where you kind of put layers on so it reflects the ultraviolet lights. Liniments is kind of similar to emollients, but those, they tend to kind of get rubbed in. So like Bengay, so or the muscle, the stuff for the achy muscles, where you basically kind of put it in, you actually kind of rub it in, and it basically gets absorbed that way. Okay. Diet. So in general, for the most part, you can have diet supplements, so you can take extra nutrients and minerals and vitamins. Okay. For the most part, folks that are healthy generally don't need additional stuff. Okay. And the therapeutic index is pretty wide, so you can generally take those. Now, as we get older, or under specific circumstances, if your body isn't able to absorb or produce certain, whether vitamin D or vitamin potassium or vitamin K or whatever, then certainly we need to kind of take supplements to get those. Okay, so we can take minerals, vitamins, and minerals kind of the same process. Right? Yeah, and then you get other diet stuff that kind of starts to regulate the your metabolism within reason. So how much, because you're kind of really getting into the TV claims where they're going, this will help reduce fat, or you can take this medicine and it's going to cause this to occur within the next 30 days. So anyway, kind of some have some legitimacy there, some don't, so kind of really kind of buyer beware. All right, you want a break? Okay, so moving on. Cancer, infectious disease, inflammation. So cancer, infectious disease, inflammation. There. All sorts of anti-stuff. Yeah. All right. So anti-neoplasty. What's that?
Chemo.
Yeah. So how do they? So what's the difference? So you have cancer cells and normal cells. Characteristically, what are the differences between those? What is it? Okay, so they have an abnormal shape. What else? Right. So they have a much greater increased rate of growth than normal cells. So one of the things that they've kind of started looking at is basically we can just start killing cells. And certainly we start killing healthy cells, but typically we kill the faster growing cells in the greater proportion of the healthy cells. Okay. And so that's what they're looking at, things that rapidly reproduce. So certainly it causes effects systemically, but that's kind of what it is. So there's a couple different ways they look at this. Anti-metabolites. What's a metabolite?
The byproduct of metabolism?
It's an enzyme used in basically, yeah. So we have metabolism, which is basically the build-up and breakdown of stuff.
Yeah, so it'd be something that breaks down or stops the cell production.
Yeah, well, it's something necessary for cell production, so it kind of inserts it into the place of whatever it is,
So it blocks.
and now that cell can't build out. Right? Okay. Mitotic inhibitors. What's mitosis?
Cell division.
Cell division. Right. So basically, you can inhibit cell division. You inhibit cell division, it dies, or it doesn't continue to grow. Right. And alkylating. I want to say it works kind of on the cell. I don't know. What's alkylating? DNA
No,
splitting.
no, stick it out.
What?
DNA, splitting of the DNA. So basically, the alkylating ones interfere with DNA, how the DNA breaks apart with the DNA RNA process. So, do we deal with these? No. Well, hopefully not. Basically, folk can do chemotherapy at home now. So we kind of need to understand there's different mechanisms. We need to understand this stuff's kind of dangerous. There's lots of side effects. And so generally, if we treat them, we're going to be dealing with the treatment of the side effects.
Right, like pain management.
Antibiotics. So these interfere with bacteria. And there's two broad, there's all sorts of smaller classes, but broadly kind of what they do. They have bactericidal and bacteriostatic. Bactericidal kill the bacteria. The bacteriostatic just prevent them from reproducing or prevent them from growth. And ultimately, they will die their own natural death. Okay? So, inhibits cell wall synthesis. So if you can't build up a cell wall, it dies, right?
Right.
So penicillin, cephalosporins, vancomycin, okay, those inhibit cell wall synthesis. Right? Protein synthesis. So they need the necessary components. Okay? So these tend to be bacteriostatic, don't necessarily kill them, just kind of limit what they can do. So the macrolides, aminoglycosides, tetracycline, those function that way. That make sense? Okay. All right. So a fungus is what?
So it's a pathogen.
It's not quite a. It's a different class than a bacteria, but yeah, basically it's another kind of living organism. Right? But yeah, so basically they have things that are specific to fungals. So we can get fungus infections or fungal infections. So you can get those on your feet. You can actually inhale them and get them inside. Okay. But basically these will work against those. And there's several different classes of these. Okay. So we just kind of understand there's different ways that you can treat fungal infections. Okay. Antivirals. Okay. Work with viruses. Okay. Generally, when's the best way to give antivirals?
How?
Well, when? Yeah.
What, preemptive?
Yeah. Well, basically, kind of very early. So, like, if you have a cold or flu, if you get there within a couple days of you developing it, they shorten the span. If you wait a week and then go in, it doesn't do those two. They don't do as much.
So that's why, like, for rabies, if they think there's even a chance, I'll start it before they even find out, before they even test. And
Yeah. Well, but I think that has to do with kind of the process in which the disease progresses. But yeah. Right. A couple things. Retrovir, AZT. What else is there? I heard of Retrovir, AZT. Know what it's for?
HIV.
So if you kind of know some of these, actually I'm not seeing what they're anyway. So knowing some of those, like this one, would probably be good, just so that when you see it, you can go, okay. You don't have to say anything, so that you understand. Rifampin INH is another one. It's for tuberculosis. But yeah, there's different antiparasitic, hemolytic diseases, so there's all sorts of stuff that you can treat. Thing is, you have to kind of figure out what it is. So again, kind of once somebody's sick, we kind of go, what is it broadly? And narrow it down and kind of start figuring out. Okay? Gout. What's gout?
Build of uric acid.
Okay. Yep. So there's basically treatments that kind of will help break that down and increase the breakdown of the uric acid.
So is the reason, I mean, you're right, the reason that gout works for, like, is the reason that it's kind of in your feet, is that